Good afternoon, everyone, and welcome to this session on Confronting Non-Communicable Diseases, the Universal Health Coverage Challenge. My name is Anselm Hennis, and I'll be moderating this session. And as you know, regarding universal health coverage, it means that all people have access to the full range of quality health services they need, when and where they need them, without financial hardship. It covers the full continuum of essential health services from health promotion to prevention, treatment, rehabilitation, and palliative care throughout the life course. And as you all know, universal health coverage is firmly based in the 1948 WHO Constitution, which declares health as a fundamental human right and commits to ensuring the highest attainable level of health for all. Non-communicable diseases, namely cardiovascular diseases, cancer, diabetes, and chronic lung disease, are collectively responsible for 74% of all deaths worldwide. And about a third of such persons with NCDs die prematurely before age 70. The COVID-19 pandemic has exacerbated the challenges that people living with NCDs face, given the role of these diseases increasing the risk of adverse outcomes from COVID-19, including complications and premature death, as well as delayed and foregone care due to disruption of health systems and services. Today's plenary provides an opportunity for us to hear expert opinions and to dialogue and share on this whole topic of confronting NCDs, Universal Health Coverage Challenge. So I'm going to introduce my expert panel before we begin. And to my immediate right is Dr. Bente Mikkelsen, who is Director of Non-Communicable Diseases at WHO. And she was formerly Director, Division of Non-Communicable Diseases and Promoting Health through the Life Course at the Regional Office in Europe. She's also the head of the Secretariat of the Global Coordination Mechanism on the prevention and control of NCDs. Dr. Mikkelsen is trained as a gynecologist and obstetrician and holds a master's degree in health administration and management from the University of Oslo. Her current focus is on achieving the SDGs, Sustainable Development Goals, through the reduction of premature deaths from NCDs in the context of the WHO General Program of Work and working across sectors with multi-stakeholders within and beyond the health sector using innovation, implementation research, health literacy, and new technologies. Then on her right is Ms. Deanna McGee. And Deanna is currently the Global Advocacy Portfolio Lead at the American Heart Association, and she has over 15 years of experience working and leading nonprofits and various aspects of their mission delivery. Her public health experience is primarily in the areas of nonprofit capacity building, international relations, advocacy and diversity, equity and inclusion efforts. In former roles, she has launched international leadership programs, led organizational diversity initiatives, consulted in strategic planning, and serves as a lobbyist to garner support for education and advocacy efforts focused on women's health and health disparities. Diana brings a solid history of program development, management, and overseeing projects in over 10 countries, and a unique perspective to grassroots mobilization and civic engagement. She holds a BSc in Business Administration from Stony Brook University and a Master's in Public Administration from New York University. She lives in Virginia with her husband and her twins, so I understand are about to finish high school. On her right is Dr. Joe Buford, and Dr. Buford is Clinical Professor of Global Health at the New York University School of Global Public Health and Clinical Professor of Pediatrics at New York University School of Medicine. She's President Emeritus of the New York Academy of Medicine and immediate past President of the International Society for Urban Health. She served as Dean of the Robert F. Wagner Graduate School of Public Service at New York University. And prior to this, she served as Principal Deputy Assistant Secretary for Health in the US Department of Health and Human Services. Dr. Buford has served in several boards, and too many to mention, and was elected to the membership of the National Academy of Public Administration in 2015. She's a fellow of the New York Academy of Medicine. Dr. Buford attended Wesley College for 2 years and received a BA in psychology and graduated magna cum laude from the University of Michigan and with her MD with distinction from the University of Michigan Medical School. She's board certified in pediatrics. Welcome. And The final member of our panel is Dr. Junaid Razak. Dr. Razak is the Director of Research in the Department of Emergency Medicine at Weill Cornell Medicine and Director of the Center of Excellence for Trauma and Emergencies at the Aga Khan University. Previously, he served as the founder director of the Center for Global Emergency Care and Professor of Emergency Medicine at Johns Hopkins University. In addition, he has served as the director of the World Health Organization Collaborating Center for Emergency Medicine and Trauma, chair of NIH's Collaborative and Enhancing Emergency Care Research in Low and Middle Income Countries, and CEO of the nonprofit Health System in Karachi, Pakistan. Dr. Razak's research is focused on the intersection of emergency care and public health. He has received numerous awards for his global health contribution, including the Presidential Lifetime Achievement Award by the Global Emergency Medicine Academy. Dr. Razak did his training in medicine at the Aga Khan University in Pakistan, completed his residency in emergency medicine at Yale University, and has a PhD in public health in the Karolinska Institute. Welcome as well to you. So with that profile and our participants, I'm actually going to begin by posing the first question to Dr. Mickelson. So, Bente, NCDs constitute the major global burden of disease, disability, and mortality. Please describe the efforts led by the World Health Organization to advance towards universal health coverage and how this has been impacted by the COVID-19 pandemic.
Thank you very much, Dr. Anselm Hennis. And it's an honor to be here at this fantastic panel. And now I see the whole room is also filling up, which is very, very nice. So you have already set the scene, and I don't know how many of you actually work on non-communicable diseases, but I'm 100% certain that if I asked you to raise your hand, everybody is directly or indirectly affected. And still, we struggle, all of us working on non-communicable diseases, to voice the big need for our populations, both at risk and also living with NCDs. So that is the very serious fact that I think we need to sort of really have as a buzz when we move into the discussion today. So Dr. Hennis has already said, and it's still a huge surprise for many policymakers, that 74% of all global deaths is due to NCD. And I have started to talk about immorality in this field of work. If we just look at the most common cause of death, namely cardiovascular diseases, which causes 1 in 3 deaths globally per year, 54% of this is actually due to hypertension. And that means that 1.3 billion adults has an hypertension. Only approximately 50% know that they have an hypertension. And just think about, what does it take actually to know that you have hypertension? It's not a very high technical thing. It doesn't actually require a lot of education. It requires training, yes. And when we then look at how many of those are treated, only 43% worldwide is treated of those who have the diagnosis, and only 20% is actually managed. This is something to think about. And I think we, from the non-communicable disease area, we need to make this very tangible. I think we have been very good in making it tangible when it comes to tobacco, to the risk factors people understand, but they don't really see the link between the risk factors and the diseases fully yet. So what is this about UHC? So one thing that the field of non-communicable diseases does not lack is political commitments. We have tons of political commitments. We have had 3 high-level meetings. We have 3 political declarations. And if you look into them, they all consist also of commitments for UHC. Today, when we look at the coverage for universal health coverage and NCD, unfortunately, the figures we have is very imprecise. So if you look at them, they look quite good, But everybody who works in this field say that we don't really measure it. And I think the example of hypertension is a very good one. We see that we don't have a health system to respond. And if we look into the access to medicines, it's even worse. In the Euro region, we looked into what was the main reason for out-of-pocket payment. And that was, of course, lack of access to medicines and lack of treatments. So I think we can, at a very early stage, say that we know that the system doesn't respond. We don't have the sufficient financial protection, as was read out by Ansel, despite the political commitments, and also despite that many of the tools that we have produced since the onset of the NCD agenda exist. Just look at the PEN package. It is in itself, a way to strengthen health systems in a very simplistic way, just defining the absolute basic that any health system actually needs to provide. And from there on, we also have much more sophisticated tools, of course, like UHC benefit packages. We also have now more and more economical analysis to see what is really needed. And when you look at that, over and over again, we see that the investment is quite reasonable and the return of investment is sky high. So we have a very good pitch. But nothing is really happening. So I know that the second question is more about COVID, but I just want to say immediately that as horrible as COVID was and as horrible as the Ukraine war is, and maybe COVID still is, this has been an opportunity for the non-communicable disease agenda. Already in 2020 in May, we had phone calls from health workforce all over the world, also patients, people that were affected. They say, hey, something is happening here. We don't get the treatment anymore. And we had a survey that showed that we had approximately 60% disruption in 60% of the countries reported this disruption for all the 4 major diseases, but also even worse for rehabilitation. It was up to 70%. And of course, the people went unprotected, untreated, and we saw the excess mortality coming out now in figures from WHO. So this has been a game changer. And maybe if I have 2 more minutes, I can also say a little bit more on how we have dealt with all of this. So at WHO, we have had the best buys. We have still the best buys. We just updated them. And more now, we also have best buys that speaks to elements of the UHC. We have developed UHC benefit packages. We have a UHC compendium. We work on all the elements together with colleagues in all the different departments of WHO to try to strengthen every building block of the health system. We are doing economical analysis, global business cases, national business cases, also business cases for different things like cancer, to prove and try to develop a language that actually speaks to the Minister of Finance and the Minister of Development. So that's on that end. We have been very, very carefully looking into how the progress on the inclusion of mental health now has developed into preparedness and response. We are learning from them. We have recently got mandates, and for the first time in the history, we are actually now at the table in the Ukraine war situation, another situation at WHO, and we have deployment of people both on NCD and rehabilitation. So there has been an eye-opener. We are there, we are going to progress, but it's still a long way to go. And I think I would stop there, and I'm very curious on the other panelists, how they will look at this. Thank you.
Thanks so much, Dr. Bente. So you've outlined a number of initiatives that WHO has developed, tools for returning investments, health system strengthening. You've all spoken about the best buys, the PEN package. So WHO has a really clear mandate and program. And I guess I'll come back to the question later on of why are the countries not taking it up? given the fact that you pointed out that only 20% of people with hypertension are treated and controlled. In fact, despite the fact that 1.3 billion people in the world have hypertension. So, and you began it by preceding your comments by talking about this is a situation which might be an immoral situation. Very strong words. So I think we'll come back to getting more clarity in your perspectives in this particular space. Thank you. Okay, Deanna McGee, your question is, there have been and continue to be tremendous challenges related to the prevention and control of NCDs during the COVID pandemic. And these have been exacerbated by the disruption of health systems and services. What have some of the implications been for the work of civil society?
Thank you, Dr. Hennis. And before I begin, I think what I'd like to do is I do want to acknowledge the Native people of Washington, D.C. And I do this largely because they were the Anacostans and the neighboring Piscataway and Luvungi people who were the original stewards of the land in which we are currently right now. And I think it's important to set the tone that when we talk about these issues of health and when we talk and we frame it in a human rights framework, that we need to recall that it means the right to life and freedom, just part of when we think about human rights frameworks. And that's really recalling the ancestors and the people who were here before us. And so I do want to couch the context of what I think civil society, and that is a very diverse set of actors that are in society that are looking to find solutions on what we know as non-communicable diseases being a very complex issue. I want to actually just pose a question to all of you. Just raise your hand if you consider yourself part of the NGO or part of civil society. Okay, so I see a couple of hands going up, and I would argue and say to each and every one of you that you are part of civil society in what we are calling to do on this very issue of non-communicable diseases, which is we need action, and we need each and every one of you to raise your hand and be part of the cause and the solutions to this major issue of urgency that we're trying to bring forward. I want to say that COVID-19, we all experienced it, and it's still happening. I think we've heard at the opening plenary today about what's happened, what we're thinking about doing in the future. And I want to just bring us back. We are still, if we work in global health, living with the repercussions and the consequences of COVID-19 and a global pandemic. We're still living in a recession. I think Dr. Mickelson just talked about the Ukraine crisis and how that's impacting people's health all over the world. And so what is civil society doing? I have the privilege of representing the American Heart Association and working also very closely with my colleagues at the World Heart Federation, the World Stroke Organization, and this group called the NCD Alliance, which makes up, it's in over 80 countries, but makes up lots of regional and national alliances that are critically trying to address this issue with people being at the center of identifying solutions. And that's people living with NCDs. And so I would, if you haven't heard of them and if you haven't enlisted yourself in being and joining us on this fight, please do so. So that's my first call to action as someone who is representing civil society who's trying to get more soldiers out there on the streets. During the COVID-19 pandemic, all of us were faced with several things. We obviously saw the public health measures that were put in place that put us in isolation. Many of us in civil society were asked to fill in the gaps where government was unable to fill it. We came to the rescue of those that were most vulnerable. We tried to best represent and alleviate the suffering that was existing with patients, again, not getting their care. We lost quite a bit of people as part of this pandemic and continue every day. We're losing more and more people. And I would say that, our healthcare workforce, of which a vast majority of it is represented by women who are shouldering the burden, were impacted tremendously. And so what has civil society done? We have tried to fill the gap where government has not been able to step in and do its part. We have been trying very hard. We've been able to capitalize on technology and all of what has become the new normal. Now we don't even think twice about using Zoom or connecting, whether it's with patients or their caregivers, to provide the necessary advice and counsel as they're going through this pandemic. But we have done more with less. We have, as civil society, been agile and come to the needs, or tried to come to the needs, find creative ways to find solutions to address this pandemic and address the fight that we're in front of. I mean, non-communicable diseases is a complex group of diseases. We need health systems that are going to be strong. And we're really trying to carry that torch that says, we want to build a system, a health system that's going to be stronger for everybody, for everyone. That means that people with communicable diseases, but also people with these chronic lifelong diseases. And so I'll stop by saying that we were agile, that we did more with less, that we've been remote responsive. For responding to your first question, Dr. Menes, over to you.
Thank you so much. And so I think you've painted a really comprehensive picture of civil society. The fact that we are all members of civil society, whether or not we recognize that, the role played by civil society during the pandemic, doing more for less, being agile, being responsive, showing leadership. So again, thank you so much. The next question then goes to Dr. Buford, and your question is, the social determinants of health lead to disparities in health inequities. What are some of the approaches and interventions to tackle the social determinants to prevent and control NCDs?
Thank you, I think, for that question. Anyway, thank you very much, Dr. Hennes, for your leadership in putting this together, as well as I'm very happy to be here. I want to make I'm going to probably shift gears a little bit, but I wanted to make a couple of preliminary statements which build on my colleagues' comments. First of all, I do think that to tackle the broader causes of non-communicable diseases, we really need to get better global recognition that the NCDs, which are really the leading killers, as my colleague, Dr. Mickelson said, 70% of deaths, but also are only receiving about 5% of the international development assistance investments in the health systems. And this is a bad balance. And I think one of the real issues we need to do to begin to even be ready to discuss the social determinants is to, if you will, rebalance the investments, largely from acute infectious diseases and some of the historical problems, which are certainly not all solved, but nevertheless, and using an equity lens to really get a rebalancing of our investments to focus on the real killers. I think the importance of NCDs, as my colleague said, became quite apparent during the COVID epidemic, as we really saw the highest death rates in people with pre-existing conditions, largely untreated or unmanaged or unidentified chronic diseases, diabetes, hypertension, chronic pulmonary disease, and cancers. So the second point is, I think we also really I think uniquely within global health have this NCD Alliance, which has been referred to, and it's kind of a unimaginable coalition of global organizations focusing on different diseases with the International Patient Association for many, many years, who really put chronic disease on the agenda of the UN at the General Assembly. When they initially started, I was, in deference to my colleague, I was saying the Caribbean Ministers of Health really were responsible for that kind of action, along with Sir George Alene. And partially the reason for that was a recognition that the shared risk factors for alcohol, unhealthy diets, physical inactivity, and air pollution were shared by all of these illnesses. And if they could band together to really look at how do you tackle those problems, the NCD incidence could be reduced dramatically, because again, so many of the non-communicable diseases are in fact preventable. So they are also the highest cause of preventable death in the world. And so those are the sort of two background points. And involving the social determinants, in my experience, one of the issues is we have to really be clear on what we're talking about when we say social determinants of health. My clinical colleagues are really talking about the social support services that a patient, individual patient needs to manage a chronic illness and a chronic complex illness. And that's very different from what the public health profession think about, which is the conditions in communities that the patients go back to, where they live, where they work, and other activities that are providing a dangerous and risky environment for chronic disease development and a problematic environment for chronic disease prevention. And to tackle those issues, the combination of the medical care and the conditions in communities, we really need partnerships between the healthcare delivery system and other sectors of government. And I think we don't see this too much yet. It's beginning, especially in cities. I do a lot of work in urban health. But if we're going to really address the non-medical social determinants of health, like economic development, housing, nutrition, social services, in addition to healthcare, we really need ultimately cross-sectoral work, and that means political leadership and political support. Now, one of the couple questions come up immediately. Do we have an evidence base for investing in the non-medical determinants of health? And the answer is yes. I think 10, 12 years ago, we would not have been able to say this, but now thanks to Sir Michael Marmot and his work and WHO's leadership many years ago, actually now almost 20 years, on social determinants of health, the database has really been developed and is very clear about the importance of social supports for the individual patient and interventions that have shown to have effect in the community for sort of relieving some of the risks that are in people's environments. And I think this multi-sectoral intervention, we know that if you have a transportation policy that promotes cars, you're going to likely to increase air pollution. If you have unmanaged urban planning, if you have good urban planning, you can have green spaces where people can exercise and have activities. If you use your regulatory and legal frameworks, we can deal with quality of food, the ability to regulate smoking in public places, et cetera. So these are all interventions that have been going on for some time, and the evidence base is, I think, very arguably supportive in terms of return on investment. And I work a lot, as I said, in cities, and I think we see a very special kind of political commitment among mayors using what WHO and others have called the health in all policies approach, which really says, whatever investments you're making in whatever sector, look at the health lens, look at the equity lens, see how those decisions might be made quite differently. And WHO has given us a very nice model with the Urban Heart Program, which really looks at the way in which cities can integrate interventions in the clinical side, as well as in the community conditions side. There are a number of public-private partnerships in cities. Novartis Foundation is working on Better Hearts program with American Heart and World Heart. Novo Nordisk has been working on Better Cities for Diabetes as a global program. And the healthcare delivery system cannot be expected to solve these problems. What we need is to move away from a sole approach on a medical model, which of course is essential services and essential medicines, but also combines with a cross-sectoral approach, looking at the causes of the risks that patients are involved in every day outside of the examining room and outside of the hospital. So I'll stop there. Thank you.
Yes, thanks for Dr. Professor. You gave us a lot in terms of need to rebalance financing from communicable disease to non-communicable diseases. And you highlighted the fact that only 5% of ODA goes to NCDs. And this is really quite a significant figure that shows the lack of what I consider political engagement in the real problems. And then you talked about the importance of multi-sectoral approaches and highlighted the interpretation or the differences in interpretation between social determinants from the clinical perspective and the real world perspective in terms of the conditions where people live and exist and have their being and their welfare. So that is so very important. Thanks for setting the tone for us in that space. And the need to have intersectoral, multi-sectoral approaches really if one is going to make any difference in this space. Thank you. So the next question then goes to Dr. Rasak. And tell us a little bit about your perspectives on creating linkages between acute care and primary health care, because you've had many experiences in Pakistan. So I think we'd be really interested in hearing your sharing what your experience of being in this space. So over to you.
Sure.
Dr.
Thank you so much. Let me begin with a question to the audience. How many of you identify your core job as acute or emergency care? It's a lonely place for us. A lot of people do acute and emergency care and think about NCDs. And that's the point I want to make today. Let me begin by sharing 3 facts regarding health system and build my subsequent argument on that. Number 1, primary care has a huge mandate, as we all know, preventive promotive care. When we actually look at primary care, a lot of it is symptom-based acute care. And if you look at, well, it's a challenge because the other pieces of their primary care that includes doing so much more for NCDs does not get space or time to achieve. And I see it as a challenge, but also an opportunity. So that's number 1. Number 2, if you look at the sharp edge of acute care system, your emergency department, in a high income country, about 30 to 40% of population visit an ED once a year. It's a huge number. In the US, about a third of the population has a visit to the ED, an emergency department. Karachi, Pakistan, where I worked for many years, about 20-25% of people would visit the emergency department. And half of them are hypertensives. And when they go home, they know they are hypertensives because that's the first time many of them have heard about it. But what happens after that? That's the question, right? They came to the healthcare system, they were recognized as having a problem of hypertension, and then the health system unfortunately dropped them for whatever reason. We'll talk about that in a few minutes. And the third point is NCD needs behavior change. And behavior change is not seen as part of acute and emergency care interventions, but if you look at the evidence and data, there is extremely strong evidence that for many high-risk populations and for many high-risk conditions, what we call brief intervention is very powerful if done in the acute care settings. But for some reason, we have not focused on that for diseases like hypertension and diabetes, and we have missed that opportunity. So while there is mandate and need in primary care, while there are numbers in the acute care setting, and while there is evidence, but there is no mandate in emergency care setting, is where I see an opportunity for us to grow and target NCD prevention and treatment. And you can see the false dichotomy here. You have acute care settings where you're getting a lot of patients with NCDs who are not getting the kind of longitudinal care they need. And then you have primary care, which is supposed to be providing promotive preventive care, where you see a lot of acute care. So what is that dichotomy and what's the problem with that? And I'll come to that in a few minutes. Let me share with you an example from our work in Karachi. We got a grant from NIH to study severe hypertension coming to the emergency department. And our focus was really looking at what interventions can we do in the emergency department to improve care of these severely hypertensive patients. They are systolic 180, diastolic 110, 120 or more. So very severe blood pressure. 60% of them didn't know they were hypertensive the first time they came to the healthcare system for hypertension. And we sort of divided that population into those with end organ damage, or we call hypertensive emergency, and that's a life-threatening illness. And the other condition called hypertensive urgency, which is considered not so serious. And the standard of care is, these people are going to get okay, send them home, refer them to primary care. Of the thousands of patients we screened about 100,000 patients. And we sent thousands of patients home saying that you have hypertensive urgency, you don't have to worry about it. But as part of the protocol, we called them back for 6 months, 1, 3, and 6 months. trying to figure out what's the outcome. And the questions were really, are you following up with your doctor? Are you taking your medications? Are you measuring your blood pressure? And what was actually shocking for somebody like me who's been doing this for a long time, that 5% of patients who we thought were low risk had died in the first 6 months. Very high mortality in that so-called low-risk group. And then we started to look around, and that was not, we were not the only setting where we saw such a high mortality. We saw that in Tanzania, in other parts of Africa. But if you go to a US-based model, it's 0.5%, maybe less than that. So we started to think about, so what went wrong? What was the difference between those who survived and those who died? It's interesting. Most of the patients who were sent home were checking their blood pressure themselves, were taking their medications, but actually were not following up the primary care doctors because they could not get an appointment, or it's an urban setting, they could not just get into the system. And the reason really, the lesson learned for us was, we are doing a good job in recognizing and diagnosing things, but are we doing a good job in connecting them to where they need to go? So, so coming back to this dichotomy between emergency care and primary care, my understanding is that it's a system design issue, but also a much bigger issue is how we think about health system. And we try to force patients into neatly divided healthcare system designs instead of health system responding to the patient care needs. And I think that's where the problem is. So I have a patient who's coming to emergency care but has a primary care need. I should be able to deliver them primary care instead of saying, you go out and figure it out yourself. So I think hypertension, taking the example of hypertension, more than 1 billion people, 20% treated. I think there's an opportunity where you could use your acute care system to recognize patients, but link them up to a stronger primary care system or some other system so that they have coaching and navigation available in the system today instead of creating a new completely whole system. I'll stop here. Thank you so much.
Yes, thanks so much, Dr. Razak. That was actually very, very sobering, particularly when you said those who are follow-up considered low risk, 5% mortality within 6 months. Absolutely terrifying. And I think quite often in healthcare performance, people do not know what happens next when people are discharged or are sent to go and find the way forward. So the whole issue of connectivity and access and systems built around patient needs becomes really so important and critical. Thank you for sharing that perspective. So then I'm going to pose the next question then to Dr. Mickelson. And we won't come back yet to the issues of morality. We'll leave that for after we have the discussion with the audience. But I'm going to ask you, how is WHO leading the process of recovery of health systems and services and ensuring that NCDs are prevented and controlled in the context of universal health coverage? And this is particularly in the context of coming out of the pandemic. So how is WHO leading the process of recovery of health systems and services? And I know that you did mention the fact that there were significant disruptions.
Thank you very much. And you promised that we will come back to the why not.
Yes.
Yes, because that's important. And this is a little bit on how we work. So what we did during the pandemic was to bring all the regional level of WHO, the 6 regions and HQ together. And we actually had weekly meetings to try to understand what we can do in the middle of the pandemic, but also in a kind of building back better perspective. So one of the things was that the response, the preparedness and response strategy from WHO was not very developed when it came to continuity of care, which is also touching on what you're saying. So what we did was to influence something we call Pillar 9, and it's important. So this was really how to guide continuity of care into the national response and preparedness plans. We did a check after, I think, half a year, 3/4 of a year after the Pillar 9 was really developed. And it was very, very sad because we had very few that actually had mentioned anything about chronic diseases. Some had a little bit about HIV. Very few mentioned even any of the NCDs. And when they mentioned it, it was just mentioned. So, for example, diabetes, which we know is at risk in any pandemic or humanitarian crisis, was the only one that was mentioned a little bit, but it was not really budgeted or any real thing. So we want to do that again. I have high hopes, honestly, that it is a different picture now because the sensitivity is very huge. And what made me believe that is just listening into the executive board members who all of them more or less spoke on NCD and mental health, regardless of the topic, but especially when it was about preparedness and response. So I have high hope. So that was very important. But then it was also to make an analysis. What was the reason for the disruption? And I think even more important, what was the mitigation strategies? My concern just now is, are we able to give the leadership to continue these innovations that we saw during COVID? That's really a masterpiece of leadership. It's very easy to go just back to the old frameworks and the old sort of misconceptions and conceptions. So if we look at the main reasons, the main mitigation strategy was very much community communication, explaining the situation, reduce fear of actually seeking healthcare. But of course, the real game changes was the triaging and the task shifting in the space of the workforce, and also completely new health system independent solutions, for example, for provision of medicines. And then the big topic of digital care. And many of these things came actually about, and I'm pointing at you, Diane, because it was really the civil society in combination with the people living with diseases that was pushing and sometimes also providing the solutions. We have collected a lot of feature stories on this, and we have a renewed engagement for digital health, which I think also will lead us into, some of the more sustainable solutions, with the caveat that this can also widen the inequity. We have to be careful, right? How is this again linked to UHC? Yes, almost all these components is actually health system strengthening. And I totally agree with you. I also almost constantly say the health system to respond, because we have seen that there is a development of people that only focus on health system and they don't ask for the content. And of course, we have the other ones that only focus on the content and doesn't look for the health system as such. So these are things that needs to be looked into as well. So to summarize just what we did as a direct consequence of 70% of all countries reporting full or partial disruption, was to look systematically into these elements. So first of all, it was to continue to include all the best buys and the packages developed by WHO. So we must continue to build as we originally had planned. There is no reason to not do that. The other one was to engage people with lived experience and bring them to the table, bring civil society into co-creation in a much stronger way, as we have seen for HIV, which actually were able to build a health system. You could say it was siloed, but anyway, they made the system respond, which we also need to do. And then it was to focus and harvest on digital technology, and very important to start to really measure. We have some indicators and we even have targets pointing towards health systems in the NCD Global Action Plan and the Global Monitoring System. But I think as we move into the next fourth high-level meeting in 2025, we need to relook at this. We need to relook at how we actually measure, and if we can ensure ourselves that we really have universal health coverage, or is it just a reporting which is sort of ticking the box? So I think I'll stop there.
Thanks very much, Dr. Mentian. And you point out again that while countries spoke about the prioritization of NCDs, in practice, not a lot really changes yet, although you remain optimistic.
Yes, I'm optimistic.
Thank you. So the next question is from Ms. McGee. So they have, so as we continue to recover health systems and services, as we continue to work to recover health systems and services, what, from the civil society perspective, what support do you think would be needed to scale up efforts towards achieving universal health coverage?
So I think let me start with, and I'm going to just try to continue to hone in on the participation of civil society. I think there are a tremendous amount of platforms that have been created and will be created as a result of coming out of a pandemic, right? We have the pandemic accord that was talked to, and the opportunity for civil society to engage in that process. We have multi-sectorial consultations that are happening where we need to have civil society engage so that we can, in fact, be calling for what we want to be different and for the representation of this cause. And all of the myriad of needs that I think, again, are people-centered, are about the people that are suffering from this, these deadly, chronic, lifelong conditions. But there are things that are already on the books. WHO, for those of you who are familiar with the Appendix 3, raise your hand if you're familiar, because I know that we often talk in these terms. There are some of us who are familiar with WHO's Appendix 3. These are the tried and tested public policies and clinical interventions that are low cost and can, in fact, help to address and make significant, meaningful impact if implemented. That's where, and I want to stress, implementation is where things are lacking. We have guidance, we have important guidance, we have a lot of agents, actors in civil society who are trying to simplify sometimes these guidelines so that they're implemented on the ground, but we're still failing to get the work done. And so in large part, I would say, what do we need to accelerate? We need to continue to charge on, drive, mention that this Appendix 3 now that has expanded, these clinical interventions have now expanded to reflect different recommendations depending on whether you're a low resource, a middle resource country, or a high income country, to not have actors like government and the state and the private sector to sit back. I do want to stress that we do need to, in this case, when we're thinking about accelerating action, is to really recognize the commercial determinants of health and the innate conflict of interest that exists with transnational companies that are out there, some doing good, others who are treading in very dangerous places. It is the responsibility for us to put the spotlight where there are marketing practices that are targeting the most vulnerable, that in all of these different commercial determinants of health, right? And we know them well: tobacco, alcohol, air pollution, fossil fuels. We need to stop subsidizing the things that are causing our air to not be healthy to breathe. I mean, those are and I think for us in civil society, we've been working very closely on how do we message this blanket and this umbrella terminology of non-communicable diseases to be attractive for action. It is a challenge, but we're messaging more simply so it gets at the heart and the mind. We talked a little bit this morning, and I want to bring this back to this discussion, is the current way in which the WHO is being funded, of how governments are funding health budgets. We need to rethink how we're doing that. It is at the mercy of the goodwill of all the technical folks that we have at WHO, at academic institutions and agencies that are charged with this mandate. But is it working when money is tied to donors in very specific restricted areas? And so we do need to, to think about things differently, about trying to ensure that we do have an agency, and it's been a big sort of advocacy on behalf of civil society to say that the WHO is an important institution that needs to know that it has sustained funding for the long haul for us to address these pandemics. Lois Pace from the US government said today, you know, we don't benefit, we're not getting the kudos and the awards for planning, but we need to remember that we need to plan for that next pandemic that's just around the corner. And so I would say that we will continue to stress Appendix 3 on this point. You know, for those of you who are not familiar, they work. They are low-cost interventions that, you know, we need to start implementing. Fiscal policies, we need to tax the bad stuff. We need to tax the sugar. We need to tax the tobacco. We need to tax, you know, this will bring money to the coffers of national governments. And we still have just a lag in countries adopting that. And we're in a global recession. So now as agents of civil society, we can in fact say, here's a really easy solution for you all to adopt. So I'll stop there, Dr. Hennis, and turn it over back to you.
Thank you so much, Ms. McGinn, and really highlighting the need for civil society to engage. You talked about Appendix 3 and the importance thereof, and just to sort of give a bit more clarity. So Appendix 3, it's actually undergoing a revision or even as we speak, but it looks at the cost and the return on investment of various strategies to limit risk factors for non-communicable diseases. So it really is based around tackling tobacco, alcohol, diet, particularly salt, improving physical activity, and also the availability of medications for diabetes and cardiovascular disease. So it looks at issues such as health promotion through campaigns, education, regulation, and taxation to really reduce consumption of materials and substances that are toxic and injurious to health. And that really is the basis of Appendix 3. And it really does it in terms of cost-effective strategies to promote health and to reduce noxious exposures. And then she spoke again about the wide-reaching, pernicious, malign hand of the commercial determinants and those agencies and companies that back them. And of course, highlighting air pollution. That's a new topic in terms of risk factors that we really have not done well with as yet, I would say, throughout the organization. We have a lot more to do in terms of WHO, in terms of really raising the prioritization of air pollution. So really a lot more that needs to be done. There are lots of tools that can make a tremendous difference. So thanks for sharing those perspectives. So I'm going to pass on then to Dr. Buford. And your second question is, how do the social determinants of health ultimately relate to universal health coverage?
Thank you. I think my short answer is that it could have, but my sense is that it has not. I think conceptually, aspirationally, when it was first proposed, I think the early definition you mentioned, Chair, was access to appropriate medical and public health services. Actually, public health was there without great financial hardship. And then when the beginnings of publications came, we lost the public health side and it became health services, which really means healthcare to most people. And I think was defined as, you know, essential services and essential medicines, all very, very important, but sort of to harken back to what I said earlier, I think put us back in a more traditional model of how do we strengthen the healthcare delivery system rather than looking at how universal coverage might be a lever for really strengthening some of the elements of the broader health system. The second thing I'd say about it is I think the premise on which UHC was based was sound. The notion that there's government funding for healthcare delivery, there's private insurance, and there's self-pay, a lot of self-pay, which was in the low-income countries, which is why a lot of the motivation was there. If we could only harness and integrate those funds, there would be adequate coverage for adequate funds for universal health coverage. But I think the problem, obviously, in low and middle-income countries is that governments are not able to fund at the level even they would like to. Aspirationally, private insurance may not exist, and obviously then we're left with the poor really feeling perhaps the burden of paying for their services. So I think that in that second step of sort of what does it mean by essential services? What do we mean by essential medicines and who gets what? There was really no priority set for encouraging countries to use the financial incentives for creating UHC to rebalance and reconfigure their healthcare delivery systems. I think ideally Appendix 3, which I know how to label now, and then public health, and then primary care, and then specialty care, and then hospital care. It would have been in that order. And I think what we've seen so far with universal health coverage is it's largely funding the system as it exists, which is dominantly hospital care and really catastrophic coverage in some countries before money is no longer available. And I think the thing that would be an opportunity, which I think perhaps with linking with NCDs, would be to maximize this sort of design of health systems to prevent death and disability at lower costs. Many countries have been able to do it. And I think there are only about 45 countries are declaring themselves being above the 90% level of universal health coverage at this point in time. We don't know exactly what that means in the different countries, but it's really still in a formative stage. So there would be an opportunity perhaps to go back to the original aspirational goals of UHC, which was to sort of think about where do we put our dollars first in order to create the most health. And I think that's something that I would see sort of finally that going forward, prevention and treatment of NCDs in the way it's been discussed here could be a catalyst for really advancing social determinants of health within the framework of universal health coverage. And I want to say sort of 3 points to finish. What would that look like? One would be going back to the original definition of alma ata. I like quoting this. I teach it to my students because we forget about history. But if I may very quickly, the original definition of the elements of primary care in alma ata was education for prevention, promotion of food supply and proper nutrition, safe water and adequate sanitation, maternal and child health care, including family planning, immunization, prevention and control of local endemic diseases, appropriate treatment of common diseases and injuries, and prevention of essential drugs. That is the best integration I could see of social determinants and other health determinants being integrated into the healthcare delivery system in primary care. So that's one, is let's think about returning back to that definition. A second point would be seriously really thinking about integrating the healthcare and social care budgets in countries to look at a more comprehensive approach to prevention and reducing costs in the healthcare system. In the United States, we put $1 in the healthcare system for every 90 cents we put in the social care system. In Europe, $1 in healthcare, $2 in social care. So that balance is really showing off in terms of longevity. It's just the facts are really there. And finally, coming back again to the earlier point, really, really important to integrate the healthcare delivery system and public health into dialogues with other sectors, understanding how they can make health promoting decisions, equity promoting decisions in transportation, in housing, in economic development, in environment in a way that will really create healthy and safe environments for everyone. And we haven't talked about workforce. I won't go into it, but I think without it, we are all deluding ourselves into thinking any of this can happen either in public health or in the clinical system. So thank you.
Yes, thank you very much for that very comprehensive perspective. Thanks for reiterating the whole issue of alma ata. I don't think they talked about NCDs in those times, unfortunately. I do remember alma ata is probably still in
the elements are there, right?
Exactly. But I think raising the message so that includes the biggest burden of illness, and perhaps that's my personal bias, but the elements are definitely there. And I think if one applies them the way it was intended, we've been in a far better position now. Thank you so much for that. Very, very clear perspective. Dr. Razak, your question. What is your perspective on the role of acute care in achieving universal access?
Great. Thank you. Before I get into the question, it's reminded me your discussion alma ata. On day one of our medical school, first lecture was by Professor Jack Bryant. Jack Bryant was U.S. representative who represented U.S. to alma ata meeting. And at AKU, Aga Khan University, our first talk was on public health. And he asked the question, So, I have this was a picture of a young man. He said, is this guy sick because he's poor, or is he poor because he's sick? And I think that conversation started, I'm sure, much before Almata, but also culminated really clearly at that time. There's another anecdote based on what Ms. McGee and Dr. Mickelson were talking about. Several years ago, about 15 years ago, I was part of a team. Actually, led the team to organize to put together a community health program in suburban Karachi. And at that time, a lot of people were not talking about NCDs, but we said, let's start having blood pressure equipment and glucometer with the community health workers. It was 2008-9. So I would sit down in the community and we'll have engagement and sessions with them. And there was a bunch of men and women, and we were talking, and we said, what do you like about my program? We have this program, we're spending a lot of money in this, is a private sector funded program. And to my surprise, they said, what we love most is they check blood pressure. And I'm like, these guys are so ahead of the game, right? Community, the society, were very clear on what the problems are and what these guys need to do. And just to take one step forward, we got a private foundation come and say, we really like this program. We'd like you to expand it. But you need to drop this NCD business. I was like, why? I think this is what makes it really interesting and important. And I say, but that's not our mandate. That's not our mandate. So you need to drop it. I'm just giving this example because I think in real world, there's so many forces that are coming into play. But if you ask the community, they were very clear what they wanted from the community health program. Now, to answer your question on the role of acute care in NCDs in achieving universal healthcare, I think there are four things that they need to do. Or I'm just a pure clinician, not as smart as some other people here. I'm sort of very tunnel vision, but I think we can do four things. And I say first is save. So our role primarily is to save a life and reduce disability. And there's good evidence that we can, through interventions for myocardial infarctions, strokes, diabetic ketoacidosis, we can actually save a lot of lives if we do it right early. The second I is initiation of the dialogue. We often don't do that. And dialogue is about the key conversation around what is the problem, why are you here, and what could you do to prevent this? And what's the big picture here? If you're today you didn't have a heart attack, your chest pain, but your blood pressure was really high, we need to do something about this. Let's have this conversation, initiate the conversation. And as I mentioned before, populations are ready for that conversation when they come to the acute care because they're really kind of scared and they're ready to listen. So that brief conversation becomes very important. So that engagement, the initiation, that discussion is important. The third part of sync is navigation. How do we navigate people who are coming to the acute care system because they can't find a way around health system? And how do we help them navigate the health system, complex health system, to find the right place? I used to run an emergency department in Karachi. And the number one reason for a call I will get is, who is the right doctor to see for this problem? And often, one day I got a call from the local minister of health for his mother, said, Dr. Junaid, who is the right doctor for this? Like, you're the health minister, but it's so difficult to navigate for a lot of people. And how do you get there? I think that and in the US, and I'm sure other places, oncology, for example, had done a very good job in navigation. And now more and more emergency departments are doing a good job in creating these navigators who will link people in the acute care setup to the primary care setup and allow that. And not just care, but also the social services. What are the barriers to access to care? I think that's an interesting discussion. We also started working in Pakistan on the civil society question. And we run a program called Pakistan Lifesavers Program. And what we're doing is we're taking high school, college students, and we're teaching them life-saving skills.
CPR.
So CPR and all that. But the most important thing that I think I'm teaching is when do you access emergency care and what emergency care to access? Because I think a lot of people end up will go to the wrong hospital, will not know what to do, waste their time. And young people very quickly learn these things. So as part of, I'm sure, AHA and others were thinking about this, if you start expanding their role of life-saving includes allowing them teaching them not just right skills, but also right decision-making capacity. I think that will save a lot of lives. So that's the navigation piece. And the C part in this thing is linking them to coaching. We really need to get people to be able to change their lives. They know what to do, but they require a little bit of help and support. I took my mom to, she lives in Karachi. I took her to a family physician, and the family physician was like, you can't sleep. She said, yeah. And she said, you should stop worrying. Stop worrying. And my mom was like, do you have a pill for that? We over-medicalize these conversations because we don't have time for real discussions. And having coaches and people who can discuss things in detail within their own context of their own reality, and finding that link from the acute care setting so that there is a community coach who can take them through this journey. So I think that the issue of saving, initiating, navigating, and coaching will lead us to achieving USC. Thank you so much.
Thank you for sharing that really very interesting perspective, saving, initiating,
Nice.
navigating, and coach. That's a take home for all of you here this afternoon. So at this point in time, thanks for that contribution. I'm going to open for some audience questions. Let's see, by a show of hands we have. Oh, wow. Okay. I think the lady there was the first hand up. Okay, well, since you're there's this gentleman here. He's right here. I think we can work our way back to the lady in the back. Okay. So you have the first question, sir. Is it working?
Well, this is Surinder Agrawal. I'm from University of Delhi. I'm retired there and living now in the US in Fairfax, Virginia. My broad question related to NCDs. My work is also, I'm writing a book also on NCDs and urbanization dynamics in the developing countries, in particular India. So I was trying to see that the epidemiological transition and the demographic transitions, as these are happening in the developing countries, the disease burden is shifting from communicable diseases to now NCDs, and in a big way. Earlier, NCDs were considered diseases of the rich and the rich countries. But now, if you look at the disease burden, it is shifting much more proportionately to the developing countries. Second dilemma, which I find, this is the demographic and epidemiological. Demographic transition is like we see the infant mortality have declined substantially. As a result, the elderly population and the middle-aged population is growing in the developing countries. At the same time, the health systems, when we look at these, are not addressing these kind of dynamics which are happening, whether the urban dynamics or demographic dynamics or the epidemiological dynamics. These three are not missing, I'm telling you. And we have been able to address the communicable diseases, but not the NCDs. There is no political commitment towards that. The reason being, the health financing in the developing countries among the lowest. For example, India is a capital of the NCDs now. And if you look at the health expenditure and health financing, 2% of the GDP is spent on healthcare. And most of the people who are poor living in the urban areas, they are becoming, you can say, poor because of the health, and primarily because of the, you could say, health expenditure or out-of-pocket expenses, because 70% is being spent like this. So my question is that if these are the real issues, and WHO is at the center of this, and there had been World Health Assembly and so on, why we could not address this? Is there any way that we can address these issues so that the poor people who are suffering, or the developing countries who are suffering, their burden is reduced? Thank you so much. I'm sorry for a long question.
Okay, so we take that. We have two other questions to take.
Yeah, who do you want to take?
This lady was short, and I think this lady here, next to you, and we work our way to the very back. Thank you.
Hello, everyone. My name is Christelle, and I'm an MPH student at the University of Alabama, Birmingham. I actually have quite a few questions, but I'm going to pick one so we can keep this moving. So what do you think is the role of public trust in medical systems in improving health outcomes for NCDs across the board globally?
Hi, everyone. Thank you so much for a wonderful panel. I'm Katayun Madani. I'm a global surgery policy and advocacy fellow at the Baker Institute and the Baylor Center for Global Surgery, also former chair of Incision. My question to you is that as part of the non-communicable diseases, surgical diseases are under that umbrella. And most of the non-communicable diseases, either directly, such as cancers, or secondarily, such as diabetes, relate to surgical diseases. While the definition of non-communicable diseases and primary care is used, over the course of the pandemic and over the last, we'll say 40 years since Director Mahler called attention to this, surgical diseases have been neglected in terms of funding, in terms of discussions at the WHO. The last two WHAs during the pandemic, no conversation about surgery was done. And the pandemic resources that we needed were things like ventilators, masks that are components of surgical systems. How do you think we can bring some light to this issue and do a better job of planning and allocating funding and resources and leadership to overcome the burden of surgical diseases? Thank you so much.
Good. I think there's one more question in the very front, and then we can address it to the panel.
Hi, last but not least, I'm Liza Dunn. I'm from Bayer Crop Sciences, and I just have a question about implementation science. One of the things that we hear about is how do you implement some of these really good ideas? Companies have have global footprints, and they are professionals and experts at implementing very complex things. How could we, the problem with companies is that they're often mistrusted. How can we build trust with companies again, and maybe try to partner with them to help implement some of these really good ideas?
Thank you so much. So we can start the first one. So I'm actually going to pass the first question on to my colleague here, Benta, and this is about the whole issue of the demographic transition, the epidemiologic transition, and the fact that health systems are not able to cope with what is happening, and the biggest burden on middle-income countries. That's it. I'm going to pass this question first to Benta.
So actually, the political commitment on paper is sky high. And just last year, I presented 10 items to the World Health Assembly on NCD, and we get everything through. So that is not in its sense the problem. So I need to continue with the question on why, and I will not do it comprehensively, but I will just point to one thing. And it was mentioned already by Dr. Buffett as well. But the biggest problem is on the financing. First of all, there is a complete inverse financing between communicable and non-communicable diseases. So it's 2 versus 98%, and you can do the other way around with deaths and premature deaths. Why is that? And if we look at it, we'll still live in an MDG world. So all the big international financing institutions are set up for malaria, TB, HIV, and to some extent for maternal and child health. We have the Global Fund, we have the World Bank, we have the GFF, we have many other institutions as well. So what we do now at WHO is to try to support these true comorbidities. But the other thing, and that's a failure for us, we have not addressed the domestic financing as much as we should. And we have the solutions. So I'm very proud that we delivered then updated what we call Appendix 3 or the cost-effective interventions. And of course, you know, the taxation of the unhealthy commodities is one of the main, could be at least, should be one of the main contribution to increase the revenues in a place and in a space where you see that the budget, especially on health, is almost unchanged during the last year, even shrinking now with the fiscal space shrinking. So I think we have to look at financing. So that's also why on the road to the next high-level meeting, we will have the second financing meeting to address this and try to look into components that make it more feasible for countries to really prioritize NCD. But it's linked to something else, and I know I cannot do it now, so I wait until the next step.
Yeah, Buford, I'm actually going to ask you to input here as well, given your role in terms of health systems in New York, et cetera, if you want to comment on this one.
I think it's the only thing sorry. I think it's really important for us to remember that the demographic shift longevity is a public health victory, as opposed to a giant problem facing society where the health system and the pension system are going to collapse. And I would just come back to, I think one of the issues is we have not invested in prevention. I mean, part of the issue why the impact of chronic disease on the hospital sector and on the acute care sector is that so much of chronic disease is preventable if we had invested in that segment of the healthcare delivery system in terms of the best buys, the primary care and others. And there's an opportunity, it seems to me, to shift that to try to at least cope with the problem that you're identifying.
Thank you so much. Now I'm going to pose the next question to my colleagues here, Deanna McGee and to Dr. Razak about public trust in health systems. I'm actually going to start this question with Dr. Razak, and then we can ask Deanna to input.
Yeah, no, I think this whole issue of trust is critical, and we often don't talk about it because we don't know how really measure it. We don't have very good sense of what's going on. And I think the lack of trust is not unfounded. It's based on truth a lot of times. As our medical system has become money driven, very commercial, that understanding that providers will do what is best for the patient doesn't always work out. And that's why I think in Pakistan, again, people will say that, you know, the last thing I want to go to is a police station or a hospital, because, you know, you lose control and you have a bad outcome in other two places. So, but I think that other question about engagement of big organizations with much more expertise in implementation and what is there, I think there's also a big question when you are locals in many places is outsiders coming and telling you what to do. And not giving time and investment to develop local solutions that are more sustainable. I think while implementation science is important, I think the implementation science which is driven locally is very important. Thank you.
Thank you.
Yeah, so just going to the medical trust, I think the United States of America, obviously, there's a long history there about people of color and communities of color being marginalized and tested on without their consent. And so part of how, and you've read the literature, is participating and having people in the community actually lead the process. And there's a lot of different models out there in terms of engaging and creating participatory models to allow for and make room for agents like, you know, the hospital system or the politician or the local. And that's when you have a certain government that permits that, where you're a constituent and you hold a certain level of power. So what I would say in the case of building trust with the medical system is that where communities are and where there are actors that are genuinely able to find those solutions, it's that you set the table and you invite them in. And so there's just a lot of different models. So that's how I would respond to the sort of the issue of trust. And trust can be broken very quickly as well. We know that. Going to implementation science, the question around implementation science, there are a lot of different ways that certainly organizations and civil society who are recipients of dollars from pharma are constructing different kinds of advisory governance processes that allow them to contribute and to fund, but that it is country-led and it has leadership from the grassroots leading the charge, developing, what the hypothesis is going to be, et cetera. It takes a lot of courage, I would say, and there are many pharmas and private sector partners who have been able to step up and say, we're okay with not having to meddle. And so there is that, but we have to have strong sort of rules of engagement. Obviously, WHO has probably the most rigorous non-state actor engagement rules, and I think that's actually a pretty good model for private sector partners who are considering working with, the CSOs, the civil society organizations, to do that. And around sort of the surgical question, I would just argue that we do have an opportunity, just building off of some of the need for us to elevate acute care, to elevate the role of healthcare workers and their protection and their future protection for the next pandemic, that the Pandemic Preparedness Accord and those conversations around universal health coverage 2030 and our agenda, where we continue to just press on. So I would say that it hasn't been lost. I think the attention is rising on the need for us not to ignore this very important part of our health system and the needs.
Thank you so much. I'm going to ask Dr. Bentage Mickelson to respond to the question on the fact that the last two World Health Assemblies, there seems to be limited reference to the whole issue of surgery. So perhaps you may wish to.
So thank you for the question, and it's appreciated that it is actually a movement to try to raise the interest for surgical part of the diseases. And I was very pleased to see, I think almost all the health ministers of the Americas last year had the side went during the World Health Assembly, with also the no RD for AMRO present. I don't think it's lack of interest. I think it's important that we have groups here like yourself that push. That said, I don't believe that we should have specific things for laboratory medicines, for pathology services, than for surgical interventions. I think we need to read it in much more what you have been discussing today. We need to read it into the health system to respond, not ignoring any of these parts, also not ignoring rehabilitation and disability. So I think we need to ensure that the health system really respond to the whole need of the patients and the treatments. So I'm very happy that you continue to push and that you are one of those. I think that is very important. And it is true that many of the things that happened in the early days of NCD only focused on prevention. That said, I really enjoyed your saying that the epidemiological shift actually is a public health a success. Yeah. That's fantastic. But it is also true that if we have to choose among different things, we should definitely continue to push for prevention and health promotion, but also new aspects like behavioral insights and behavioral science. I think we need to broaden the scope. We need to address the people living with NCD. That was a sort of mistake in the beginning. Then we couldn't sort of capture both elements. I think we are much better now. We need to look into the need of patients suffering from diabetes, cardiovascular cancer, and then that comes with diagnostics, access to medicines, surgical training, and also the task shifting in the different levels of the health system. I know you didn't ask me now, Anselm, but I just want to add a couple of comments, because you were asking why. Why is it only 14 countries that seems to be able to achieve the SDG 3.4, namely to reduce the premature mortality with 30% or 33% actually before 2030? And that is a very, very important question. That is also why, and that's a good news for you, that the member states during World Health Assembly last year, they agreed on an implementation roadmap. So what I think you can see now is that we are sort of a little bit done with the big concepts. We have almost all the tools we need. What we haven't done yet is to implement at scale. Good news is that you almost have any of what we call the best buys or the Appendix 3 implemented somewhere. And all the time, but we don't have it as a system or a structure. So that's why the member states wanted to really now ensure that the government of the single country take the leadership, that they do the priority setting that is needed within their flexibility, and that we build on data. And I think this is very, very important. It's very important there from the global level, actually by the member states themselves. And this is also why we now have launched, for example, the NCD data portal, where you can see the NCD epidemiological picture for every country of the world. And we will also supplement that by visibility tools, so you can see what will happen when you implement different things. So that is important. So financing, we have mentioned, the health workforce is really, really important. It's not only important for NCDs, but since we are the major trunk of any health system, it is especially important. And I think the training is still very pitiful, especially when it comes to the public health interventions, but also, as you have been beautifully, I think, telling us during today, it is the sort of the holistic view of the patient, the need for many different specialities coming together, but also to really build on what we have seen during the HIV mitigations as well, that we need to use other elements like the community-based care much more than we have done before, and so on and so forth, until self-care. I think that the misconception of non-communicable diseases being complex, being still only with the rich and affluent, needs to be really addressed. So we have now started, and you heard Anselm do that in the beginning as well. We don't only speak about NCD, we list what we are speaking about. And I think that is the only option, because people don't feel they have an NCD, but they do have hypertension, diabetes, cancer, and all of the diseases. So we need to be able to mobilize everybody to feel like civil society. We need to give them back the picture, and that we really see their trouble, their need, their demand, and that is very important. And that's where the hope comes, because I can see that people with lived experience, both at risk but also with disease, now is stepping up in a completely different way than we saw only a few years ago. And that puts pressure on all of us, including the governments. Thank you.
Thank you so much. So to close the session, I will actually ask the other panelists to just give us 2 key takeaways that they wish you to remember. So I'll ask this of Deanna.
Okay, so very quickly, and I think just building off what Bente said, accountability. You have the power to create accountability, engage as a civil society actor, and remember that you vote the people in. Okay, so don't let go of that power. So I'll leave you with that. The other pieces, just to reiterate, the persons living with these conditions are where the power lies. Invite them in the beginning, the end, the middle, all throughout the process. So people living with NCDs are extremely powerful agents of change, and should be at this table as well.
Thank you so much. Dr. Buford.
Yeah, 2 points. I think rebalancing national and global investments to the real causes of disease, of death and mortality, death and morbidity in countries' NCDs, and focusing on the prevention of those if we're dealing with concerns about cost to the healthcare system and social system. The second point I'd say is I think it's really important that we as healthcare professionals really engage with our social care colleagues and other sectors, understand how they can improve health, really having this integration between social determinants in other sectors, social services, and within the health sector is really crucial to the future. If we don't really, there are much larger amounts of money being spent on urban infrastructure, for example, or infrastructure. Is it highways or is it mass transit? I mean, these are huge, hundreds of millions of dollars, loans coming from IMF, countries asking for one version or another, and they make huge differences in health, probably more, frankly, than the healthcare delivery system or broader public health practice.
Thank you so much. Dr. Razak, your two takeaways.
Yeah, the two words for me are linkage and implementation. I think our ability to be successful in NCD is going to be based on how do we bring together the system. And I think technology today, even just a telephone, is much more available than before, and using that would be helpful. And implementing Appendix 3 or Best Buy or whatever, we know what works. Let's try and do a good job in implementing this.
Thanks so much. So thanks to my panelists. Thanks for your contributions. Thank you to the audience for participating and being so attentive and sharing your perspectives as well. Thanks to the organizers. So thank you. This is the end of the session at Confronting NCDs Universal Health Coverage Challenge.
So, Dr. Razak, we should get you engaged. Maybe you were part of the Lifesaver